Good morning, everybody. Once again, your friend Dr. Salim is here with you guys. Somebody was asking if I could explain a little bit about the international protocol for the cerebrovascular studies, evaluation of the arterial system for the cerebrovascular system. Okay, here is the deal. Everybody have their own protocols. I mean, like any radiologist, cardiologist, vascular specialist, or any other doctors who are related to this field. They have their own protocol. Some doctors will ask for a short protocol. Some will ask for a long protocol. But let me tell you, what is a standard protocol, which is most of the hospitals, healthcare providers, they use it. So due to my knowledge, the one I do it, my experience, and I apply that protocol for the cerebrovascular studies, evaluation of our arterial diseases, to see if our brain is getting enough blood or not, and also meanwhile to see if there is any arterial diseases, if it's related to stenosis or if it's a dilatation, abnormal dilatation, aneurysm or something, or any type of aneurysm, or if it's stenosis. So the protocol is starting from the CCA. One more thing, it's always bilateral. So our protocols for any arterial diseases to evaluate, to rule out any arterial disease, so it is bilateral, because you guys know most of these diseases are systemic diseases. But anyway, so we started from the carotid artery. It doesn't matter right or left, it's not important. But for example, if you start from the right carotid artery, so we take sagittally and transverse images, short axis and long axis. For the short axis or transverse images, we try to take the prox, mid, and distal area for the carotid artery. We take to see if there is any plaque buildup, dilatation, or any pathology, we can catch it. So we take a gray imaging, 2D imaging, and also we're looking for the color Doppler. So if any of these we can catch, we just take those pictures. And also, so it's proximate distal of the CCA, and then we go more higher a little bit to the bulbous area, to the bifurcation. And then after the bulbous, we take the bifurcation to see that the CCA after the bulb, it's just separate from each other, to see the ECA in ICA. These are all 2D image and color Doppler. Keep in mind that when you're taking the color Doppler images for this, put your box in the center. No steer to the right and no steer to the left, because there we're looking to just divide from 90 degrees. That's the only reason on that area. Okay. And then after that, we come to the sagittal images or longitudinal images. We start again from the CCA proximal area, and then try your best to see that curve, which, if it's a right CCA, to see that innominate somehow, if you can see that, the brachiocephalic artery. If it's the left CCA, try your best to see that arch area, if possibly. Go how much you can go more down to the clavicular bone area to see the real paroxysmal area or portion. So prox area. Take the gray image and try your best to see all intima continuously, if it's a normal study. So try to see the intimal area all the way. And then evaluate, of course, for the intimal thickness, plaque buildup, dilatation on the 2D image. And then after that, put color Doppler on. Okay, here, the box can be to any direction, but most commonly, to make it easier for you guys, for the proximate distal of the CCA, if it's right or the left, doesn't matter. The box, most commonly, if you put it to the steer to the right, it just helps. But anyway, I'm not a big fan of the box to the right, to the left. It has to be the correct angulation to see the maximum Doppler shift, actually, to see the flow. Then after the color, you take the pulse wave Doppler. Try your best to put your sample volume or gate in the center of the vessel. And you guys understand that portion also, that why we put it there, because the highest parabolic flow, we find it there. And to see what is the peak systolic velocity in that area. Okay, and then after the prox, then you jump to the mid, same thing, gray color and Doppler we take, Doppler study or spectral wave phonics to see the peak systolic and diastolic flow. And then after that, we jump to the bulbous area. So after prox, mid, distal, we go to the bulbous. Now, in the bulbous, if you want to make it easy for yourself, steer your box to the left. In that case, it will give you better image quality, better Doppler flow, I can say, or Doppler shift. It will give you better Doppler shift actually in that area. So take a gray image and try your best to get the whole bulbous area, the bifurcation area, to see the ECA and ICA, and also a little bit of the distal area of the CCA. And then put color box on and try your best to cover the distal portion of the CCA itself, the bulbous, and a little bit of the ECA and ICA both. So cover everything. If you find here, okay, take gray and color, but I mean, I don't take the pulse wave Doppler in this area. If any of the doctors, healthcare providers, if they take it, they may have a reason for that, why they're taking. I don't take it. And my reason is why I don't take pulse wave Doppler on that area, because we understand there is a physiologic turbulent flow on that area where the bulbous area is. So it just makes a confusion, because when you take the pulse wave Doppler on that area, the spectral waveform, you see, it will give you spectral broadening, which is an indication for the turbulent flow. And then let's not to make that confusion. Maybe you send these pictures, these images to somewhere else, and the doctor or the reading doctor, I can say, or maybe a next doctor who gonna see your patient some other time, they may have no idea when you were scanning the patient, they were not with you, so they don't know which type of flow. So it's better to not take pulse wave Doppler in the bulbous area. It's my suggestion. You apply your protocol, but I'm just telling you the reason for that. Now, after the bulbous, we take sagittally the ECA. I mean, not important which one you should take first, but I will strongly suggest to take ECA first, and gray color and pulse wave Doppler. Try your best. If it's a normal study for the ECA, external carotid artery, try your best to find that high resistant flow, because we all know those 8 branches, they are all they're feeding, like you guys understand, the maxilla area, the muscle of the face, thyroid tissue, the ear and the temporal area, the tongue. So all these areas are fed by the ECA. And now jump to the ICA, internal carotid artery, which is the most area or the focus area for our study, because that is the artery which gives them the 75 to 80% of the anterior circulation to the brain. That's the blood goes from there. So let's make it shorter. Now I will take prox, mid, and distal on the ICA to see and make sure that the brain is getting enough blood. And if there is anything wrong, like any dilatation, stenosis, compressions, or anything, intimal thickness, or any other diseases related to the arterial problems, so I have to report it to say that the area of it, like which area, what I found. And try your best for the distal portion of the ICF, go all the way to see where you can see the vessel, the ICA is just entering to the brain, and that's like really deeper. So you go more higher by the mandibular bone, and just you go all the way, so you will be able to find it. After that, and those are all sagittal images, ECA, ICA, they are sagittal, and then CCA and bulbous, they are all transverse and sagittal both. Now, the last image we take for this protocol of the cerebrovascular studies, specifically, you can call it a CCA protocol, also common carotid artery protocol. The last one is subclavian artery. So subclavian artery, we all understand this is a peripheral artery. It's not a cerebrovascular. Why they include subclavian in this protocol for the CCA? Because we all understand we have anterior circulation, which is the ICA, and we have posterior circulation to the brain. And you guys understand that is the vertebral artery. Now, the vertebral artery get origin or start or get off from the subclavian artery. So that is the reason we include subclavian for the CCA protocol. And that is the last image we take it. Try to take it gray, color, and pulse wave Doppler. And the pulse wave Doppler for the normal study, we have to see really triphasic flow, because like I said, that is a peripheral artery and it has to be triphasic flow. And now for the CCA, try CCA and ICA. Try your best to get the peak systolic velocity and diastolic velocity. And also, don't forget to get the peak systolic and diastolic for the ICA as well too. And because we know ICA is a low resistant blood flow, that's a low resistance because it's feeding the brain, the organ. And the ECA is a high resistance. So for the ECA, only try to take the peak systolic because endostolic is not accurate. We're not taking that. That's a high resistance. And for the CCA, take peak systolic and endostolic. Why? Because CCA itself is the mixture of both. ICA, we can say low resistance and high resistance. So it's the mixture of the blood flow of the ICA and ECA both. So, and also one more thing and the last thing. Try your best to look for the ratio of the ICA and CCA. How much is that? Is it less than 2 or more than 2? So how much is that? And this way it will give you a lot of idea. Thanks a lot. Once again, I hope these protocols in these images or all these information can help you, and try your best. If you have any question regarding these protocols, just leave a comment and I will try my best to explain it maybe more simple than this. And please, one thing, don't forget, if you think these videos, these small clips can help those doctors, those healthcare providers who are in this field. So please don't hesitate to share these clips with them. But also, once again, tell them to subscribe the channel. So this way they will get the upcoming notification. They will get more notification for the videos, for the clips, for the maybe more valuable information. I will try my best to explain all these. Thanks a lot and have a nice day and take care. Bye-bye.